Varicose veins. Primary varicose veins, bilateral dilatation of and elongation of saphenous veins. Deeper veins are normal. As the condition progresses, because of hydrostatic pressure and vein weakness, the vein walls become distended with asymmetric dilatation and some of the valves become incompetent. The process is irreversible. Secondary varicose veins result from obstruction of deep veins. Telangiectasis. 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 That is, spider veins or dilated superficial capillaries, arterioles and venules. They may be cosmetically unattractive but do not pose a threat to circulation. Pathophysiology and etiology. Dilatation of the vein prevents the valve cusps from meeting. This results in increased backflow pressure, which is passed into the next lower segment of the vein. The combination of vein dilatation and valve incompetence produces the varicosity. Varicosities may occur elsewhere in the body, esophageal and hemorrhoidal veins, when flow or pressure is abnormally high. Predisposing factors: hereditary weakness of the vein walls or valves, long-standing distension of veins brought about by pregnancy, obesity, or prolonged standing, old age, loss of tissue elasticity. Clinical manifestation: disfigurement due to large and discolored tortuous leg veins, easy leg fatigue, cramps in leg, heavy feeling, increased pain during menstruation, nocturnal muscle cramps. Diagnostic evaluation: walking tourniquet test to demonstrate presence of absence of valvular incompetence of communicating veins. A tourniquet is snugly fastened around the lower extremity just above the highest noted varicosities. The patient is directed to walk briskly for 2 minutes. Failure of varicosities to empty suggests valvular incompetence of communicating veins distal to tourniquet. Photoplethysmography, a non-invasive technique to observe venous flow hemodynamics by noting changes in the blood content of the skin, used to detect incompetence in valves located inside the vein. Doppler ultrasound can detect accurately and rapidly the presence or absence of venous reflux in deep or superficial vessels. Venous outflow and reflex plethysmography, able to detect deep vein occlusion. Ascending and descending venography, an invasive technique that can also demonstrate venous occlusion and patterns of collateral flow. This test is expensive. It may not be required if a careful history, physical examination and laboratory testing are done. So, 5 diagnostic evaluation: walking tourniquet test, photoplethysmography, Doppler ultrasound, venous outflow and reflex plethysmography, ascending and descending venography. Management: conservative therapies such as encouraging weight loss if appropriate and avoiding activities that can cause venous stasis by obstructing venous flow. Surgery may be considered for ulceration, bleeding and cosmetic purposes in selected patients. If patency of deep veins is ensured, surgical procedures. A single method of combination of methods is tailored to meet the needs of the individual. Sclerosing injection may be combined with ligation or limited to treatment of isolated varicosities. The affected vessel may be sclerosed by injecting sodium tetradecyl sulfate or similar sclerosing agent. Tetradecyl, Tetradecyl, tetradecyl sulfate, sodium tetradecyl sulfate. Compression bandage is then applied without interruption for 6 weeks. Inflamed endothelial surfaces adhere by direct contact. Multiple vein ligation. Ligation and stripping of the greater and lesser saphenous systems. This is the most effective procedure. Venous reconstruction or venous valvular transplant. Last one, laser therapy. Complications: hemorrhage due to weakening of the vein wall and pressure on it. Skin infection and breakdown producing ulcers. This is rare in primary varices. Thank you.